Good morning. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today. And thanks to our friends at Generations Family Health Center in Connecticut for requesting today's session, Fibromyalgia with Dr. Maria Greenwald. Dr. Greenwald has no disclosures. I'll love to tell you a little bit about Dr. Greenwald. She graduated from the Yale Medical School with honors. She completed her internship and residency in internal medicine at Yale and was selected National Senior Scholar for her fellowship in rheumatology at UCLA. She has published over 100 articles in osteoporosis and rheumatology, and she is the director of a clinical research group, Desert Medical Advances. She's also been very involved with advisory committees related to osteoporosis. She has served as a board member and chair of the Southwest IRB and Ethical Review Board, and she is currently on the board of the Annenberg Center for Health Sciences. Dr. Greenwald, it's a pleasure to have you here today, and I'll turn it over to you.
I have really enjoyed working with Maven, and I appreciate the opportunity to do little vignettes. I think of these as curbside consults, and we deal with other clinicians and try to increase the assessment, diagnosis, and treatment for all sorts of different subjects. Today's subject is fibromyalgia, and I am Dr. Maria Greenwald. I'm in California. Our sun hasn't quite risen yet, but it's getting lighter. I wanted to bring up some of the new concepts in fibromyalgia, and that is it's part of a spectrum of diseases that we think of as chronic fatigue syndrome. So I'm sure you've all seen patients with chronic fatigue, and they have different etiologies. And fibromyalgia appears to fit in that framework. So this is just a recent report in February of this year, where the NIH has been tracking patients with chronic fatigue syndrome and fibromyalgia specifically for the last 7 years. So over the years, they followed 17 patients who have symptoms of chronic fatigue, and they checked them with blood tests, physical exams, and brain functional MRIs. And what they found is there were significant differences in the immune system, cardiorespiratory function, gut microbiome, and brain activity in these patients compared to control group of 21 healthy subjects of similar age and sex. So we are looking at this very seriously because there's a lot of long COVID, which overlaps the symptoms we see in fibromyalgia. Long COVID is now estimated to be occurring in 6% of patients who had COVID. Since most of us at some point had COVID, that's 6% of the entire US population, which is huge. In fibromyalgia, it's my favorite slide. It's exactly how they come in as a new patient. Pain is everywhere, and they are sometimes crying, sometimes moving extremely slowly. They don't like to be touched because it hurts. Their skin is on fire. Sometimes they've told me ants are crawling on them, but overall, the body is extremely painful for them. So the diagnosis in fibromyalgia as of 2021 has changed a bit, and we now diagnose patients who state that there's been widespread pain for the last 3 months everywhere, both arms, both legs, back, neck, everything. And these patients don't have periods of time where they're perfect. So you don't have a bad week and then a month it's fine and then a bad week. Fibromyalgia, they're bad every single day. So I call it the good, the bad, and the ugly. How many ugly days have they had on a calendar? And it's all of them. They have very poor sleep, and that's a hallmark of the disease, and it's something we can treat. In the olden days, when I was in training in Connecticut, it was called fibrositis, and that's a misnomer because the itis sounds like inflammation. If you had tonsillitis or appendicitis, obviously you expect inflammation. So the term of fibrositis was changed to fibromyalgia in the 1980s. But if you're looking at older literature, you'll see it listed as fibrositis. There is no inflammation in FM. And back in the 70s and 80s, they actually biopsied the muscles that the patient said was so painful. And they've done all sorts of scans and testing, and it's all normal. So muscle and skin biopsies are normal. X-rays and MRIs are normal. EMG and nerve conduction are normal. So if they have symptoms of carpal tunnel, that's not part of fibromyalgia. That doesn't mean they can't have carpal tunnel too, which is treatable, but it's not actually part of fibromyalgia. Similarly, on X-ray, you'll often see over 40 patients have osteoarthritis, degenerative joint disease, but that's not fibromyalgia. And we're going to go through, it's not a joint disease. But if they have pain in their spine from DJD, that's something else you might be able to treat. So it is important to find out if they have overlays of other causes of pain. If you do labs, CBC, chemistries, urine analysis are completely normal in fibromyalgia. There's no anemia of chronic disease. There's no elevated SED rate. We don't chase labs in fibromyalgia. If you do have serologic testing when they came to you from somewhere else, that should be normal in fibromyalgia. It's not an immune disease. So the epidemiology of fibromyalgia, as we talked about, is chronic, daily, monthly pain. It's predominantly women, 6 to 1. It's also seen everywhere. So it's in the US, it's in Europe, Brazil, Bangladesh, and the prevalence is the same worldwide. The worldwide estimates of how many women have this, it's 3 to 6% of the population. Interestingly, the peak incidence starts at menopause, between 45 and 55 in women. I think personally that it's linked to insomnia that begins when women lose their estrogen. So insomnia is a common part of menopause, and for some patients, that's enough to trigger them into full-blown fibromyalgia. Symptoms characteristically include widespread pain. That's our diagnostic symptom. They will say it's tingling, it's burning. They have tremendous fatigue and often won't even get out of bed for days. There's a definite sleep disorder. And on top of this, depression and anxiety. The traditional way of diagnosing fibromyalgia was to do a trigger point exam. That's no longer required. Now we just take a history from the patient about more than 3 months of chronic total body pain. In trigger points, I find that it is useful if the patients have, for example, osteoarthritis pain in their spine, and I'm trying to sort out how much pain is from which thing. So I often will do a trigger point exam, although it's no longer required for diagnosis. I find it helpful to assess what's going on. And it also gives me something to follow with time in treatment. So if you look at the front, the first trigger point to look at is at the lower sternocleidomastoid muscle. And I want to repeat, it's the muscle, not the cervical spine. Then at the second costochondral junction, there often is some discomfort or very bad pain. At the arms, the painful trigger point is 2 centimeters below the lateral epicondyle. It's in that soft tissue right below the elbow. And if you grab and pinch that little bit of soft tissue, they will have significant pain, whereas the average person doesn't hurt there at all. over the greater trochanter. It's in the muscle part of the pain. It's not a bursa. And at the medial fat pad of the knee, that anserine area is very painful if you grab that soft tissue medial to the knee and squeeze, pinch it. They don't like that. When we are examining, traditionally, you pinch hard enough so that your thumbnail changes to red. That means that you've given a 4 kilogram per centimeter squared pressure. Some patients won't tolerate that. It's mean. So if they're yelling and crying, don't push that hard. But traditionally, that's what you do to say there's a tender point or there is none. Now, on the back side of the person, we look at the insertion of the suboccipital muscle on the top of the spine. You're not actually on the spine, you're to the side, you're lateral, but you're pushing against the bottom of the skull on the muscle. Then you take the upper trapezius muscle where you squeeze, and you can squeeze that right there. I call it the Dr. Spock spot. So if people are old enough to have seen television with Star Trek, Dr. Spock used to grab people here and they just fall. Your fibromyalgia patient will not fall, but they may be very unhappy with you when you pinch there. On the back, it's right at the edge of the scapula. So the supraspinatus muscle begins there, and if you roll over that muscle right on the inside edge of the scapula, that will be not a good spot for them. And then the upper outer quadrant of the buttock, not the SI joint, it's actually the muscle over that quadrant in the buttock. So traditionally, I will chart how much pain they have on the right or the left of each position, starting with C2 and then moving down. These traditionally in fibromyalgia, we expect 11 trigger points. There are 19 total trigger points in the FM when you score it, and it can be scored 1 to 4 plus. The 1 plus is mild tenderness. And if you squeeze your trap up here, there's some mild tenderness in most normal people. 2 plus is moderate pain, and they'll usually tell you that hurts. If you get to 3 plus, it's severe pain, and they will be more adamant that you are hurting them. And 4 plus, the patient's going to withdraw because the pain is so severe. They just don't want you doing that, and they'll wince. So when you do the exam, I don't usually say to them, does this hurt? I just go through my pinching and I watch them. And if their eyes squint or they tell me it hurts or they pull back, that's a 2, 3, or 4 plus. I do warn the patient that the trigger point exam will hurt. I say that as I'm pinching and watching their face. I will sometimes ask if the pain is small or large, if I see them wince. And the body language is very helpful. One thing I find interesting is if you pinch, especially on the one right below the elbow, if you squeeze that muscle group there, they often fill up with their skin just turns into goosebumps. And we believe that's an autonomic response to the pain. So you squeeze the muscle, the brain sees the pain, and it sends back an autonomic response. The patients are usually not aware of that. When I ask them, do you always get all these goosebumps? They often tell me they've never noticed. But on exam, I've seen it frequently. There's no warmth anywhere. So as you're feeling these areas and you're checking them out, there's no warmth. There's no erythema. There's no evidence of some sort of inflammatory process. The pain after the exam can last for hours, and I don't tell them that until the end of the exam. So I'll do a trigger point because I'm trying to sort how much of their neck pain is cervical spine pain and how much is fibromyalgia. But I tell them, I'm sorry, you're going to be achy for a couple of hours after I pushed on the fibromyalgia points. Please take a warm shower when you get home. That'll help. and just stretch it out very gently. So they do appreciate if you acknowledge what happens and they're not scared that the next hour they hurt after seeing the doctor. I don't do a trigger point exam on every visit because it's painful, but I do often perform it in the beginning at a new patient when I'm trying to sort out the causes of pain. I just thought it'd be interesting to point out, this is a traditional acupuncture picture of where an acupuncturist would insert their needles to address pain of the shoulder or pain in the forearm and so forth, or even in the hand. These are acupuncture points, but if you look, many of these are trigger points. So I think over the millennia that acupuncture has been around, they've noticed some of this pattern in 6% of the population, and it does help patients with fibromyalgia. If they are super miserable and haven't been getting out of the bed for days, I will sometimes recommend they try acupuncture. It's often covered on their insurance. And if they go, their pain will diminish a little. It doesn't go away, but it goes down. And it lasts usually 1 to 3 days. By the end of the week, their pain's back. So it's not a permanent fix, but it can get you over a very tough spot. Or occasionally I have someone whose daughter is getting married. She's mother of the bride. She just can't deal with the amount of pain she's in. And I have her see the acupuncturist the day before the wedding. Fibromyalgia on your physical exam should be a negative exam. There's no synovitis. You won't find any joint swelling. There's no inflammation. There's no heat over the joints. So classically in rheumatoid arthritis or gout, the joint's bright red in gout, and it's hot. You can actually measure temperature in the joints that are inflamed. Fibromyalgia is completely normal. You would not be able to feel anything going on in the bones. There's no contractures. Their range of motion is completely normal. If they have a restricted shoulder arc, chances are they have secondary AC joint or shoulder bursitis, which can be treated. So that's why it's important to do your exams so you can sort out what part is fibromyalgia and what part is part of the human function with DJD or osteoarthritis, or things like routine bursitis with overuse syndromes. The range of motion should be normal. If it isn't, then you have a secondary issue here. Muscle strength is completely normal. They can stand up from a chair. They can hold their arms up front for 5 minutes. There's no muscle weakness. You don't chase CPK and aldolase and all that because it's not a muscle disease that's inflammatory. So when you're seeing a new patient and they tell you they have pain everywhere, that's a good clue. Find out how long. It's literally a distortion of the pain reception in the brain. So that's why I told you in the beginning, NIH study found functional MRI changes in people with fibromyalgia, chronic fatigue. There are differences in the way their brains recover and receive pain information. The patient is often saying they have cancer, they have lupus, they're multiple sclerosis, they're extremely anxious, they feel so awful. They must have something terrible, they're dying. So they come in extremely anxious, and it's helpful to tell the patient, after you finish the exam and you've hurt them with the trigger points, I tell the patient, okay, you don't have any cancer. You don't have lupus. This is not MS. What you have is fibromyalgia, and we're going to talk about how to deal with that. Let them know they are not dying. Sleep has been poor for months or years. And if you ask them, when was the last time you slept through the night? It might be when they were in childhood. I mean, these people really have terrible sleep patterns. The affect often includes compulsive behavior and anxiety. I think this reflects a goal to control what's going on with them. And so they have compulsive behavior patterns that are part of this control mechanism. Depression is very common, and you have to remember these people don't sleep. Who wouldn't be depressed? If you remember internship, patient is often very needy, very self-centered. Their whole life revolves around their pain. So they really don't think about their children or their husband or their workload or their colleague. It's about them. It can be very demanding in the office. And I think if you treat their anxiety component, they're much easier in your relationship patient to doctor and much easier patient to office. They're often mean to the office staff. Fibromyalgia, there was a study to cause it. We didn't repeat this. This is from back in 1975, when we were trying to figure out what were the causes of fibromyalgia. So they took normal people, they recruited them to come into a Canadian clinical research center, and they prevented them from sleeping. There was somebody there kept waking them up, and they just wouldn't let the people sleep for a week. On that week, they had EEGs attached to their brain, and the EEG saw there was major changes in non-REM sleep. Phase 4 never happened. They never got to be able to get to a deep sleep. This resulted at the end of the week, all of the patients developed total body pain, reproducible tender points, and they got anxious with mood swings, and they were just compulsive and concerned and weird, all consistent with fibromyalgia. Most of these patients recovered over the next month, allowing them to sleep, but a few of them ended up with chronic fibromyalgia. Because of that, this has not been repeated. But we do know if you ask the patients, I find sometimes the trigger was when they were in the hospital for their gallbladder surgery. They were in the hospital 3 to 5 days. During that time, they didn't sleep at all because of the beeping and the nursing and someone else in the room with them. So I find hospitalization is sometimes the trigger for chronic fibromyalgia. New information about causation. This we didn't know in the past, but there are certain genetic predispositions. Some families have fibromyalgia throughout generations. So the family member is 8 times more likely to have FM, and siblings have a 13 times increased risk for fibromyalgia. Not really much we can do about that. I don't want to increase their anxiety, but in the back of your mind, if you have a fibromyalgia patient and their sister comes in, you should be on high alert that she's at risk and make sure nothing's disturbing her sleep. There is a gene called COMT. It's a CNS catechol gene. And in these families, it's considered an FM signature. It has 95% sensitivity and specificity for fibromyalgia. So there are groups of families that have a genetic or biologic reason for their fibromyalgia, but it usually takes interruption of sleep to trigger it. On an MR spectroscopy, they can see over and over again in these FM patients low pain threshold on their brain scans. So the input coming from pain is misinterpreted in the brain. However, I wanted to mention again, fibromyalgia is not an immune disease disorder. This is not lupus. This is not MS. It is, however, a central dysregulation for the perception of pain. It is real. And if you have a patient where the depression is overwhelming, it's possible to have fibromyalgia and primary depression. I often will recommend the patient see a psychologist or a psychiatrist. And fibromyalgia actually has an ICD code for patients with overwhelming anxiety or depression. It's M79.7. The psychologist, psychiatrist can bill under this diagnosis. There's no arthritis, there's no bone pain, but they're extremely anxious. They're difficult patients. So you can use this code. It qualifies under DSM, the Diagnostic and Statistical Manual for Mental Disorders. So I sort of think of it like being bipolar. There's no lab test for bipolar. There's no scan for bipolar. It's a series of symptoms. Fibromyalgia has tremendous anxiety and depression with pain and lack of sleep, and it does qualify as a DSM code. There's both a DSM-5A and a DSM-5B, both of which pertain to fibromyalgia. I'd leave that to the psychologist or psychiatrist to determine how they're doing their billing. So when we recognize fibromyalgia, I want the clinician to focus on getting a good sleep pattern. Uninterrupted sleep for 6 to 8 hours usually wipes out fibromyalgia over a couple of months. It does take time, but you're looking for a 6 or 8 hour long degree of sleep, and that seems to reset the brain. Encourage low impact exercise. Most fibromyalgias have very poor muscle tone and core muscles, and they get back pain related to being out of shape. They're really lousy in terms of their physical activity. You want low impact exercise because if they do a lot, they try to go a mile, they'll be bedridden for the next couple of days. Their muscles are just not ready for it. And that pain signal reverberating up to the brain is augmented. So you really get them in trouble if you push too much exercise. It has to be low impact and gentle. Look for 10 minutes. That's how little I'm talking about. The fibromyalgia often peaks at perimenopause when sleep patterns change. You might want to consider low-dose estrogen in a menopausal woman if her sleep pattern is disrupted. Encourage use of serotonin norepinephrine inhibitors. These have been proven to help suppress anxiety and depression, and it helps patients deal with the ongoing pain. There is a cell phone app now called Stanza, and it's basically a mindfulness app. It doesn't treat fibromyalgia, but it helps them accept and commit to treating their own fibromyalgia. There was a double-blind study done this year where some patients did the Stanza daily app for 12 weeks, and the others did some sort of cell phone activity, I don't know, maybe Wordle, for the 12 weeks. The group that did Stanza, where they answered questions and agreed to walk for 10 minutes, agreed not to drink coffee at night, all the little things you want them to do to be helpful, that group actually improved significantly. They had 70% response rate on the patients who did Stanza daily. This gives your compulsive patient something to do every day. It gives them some sense of control, that they're the ones in charge of getting better. Warn patients, however, not to use steroids or narcotics. Both of those worsen FM. So they're in a lot of pain. They go to the ER, somebody hands them a 7-day pack of Medrol. That's going to make them much worse. If you remember, steroids interrupt sleep. So you're really not doing them any favors, and that's not inflammatory. So it has no role in fibromyalgia. Narcotics, I'm not exactly sure the mechanism, but they always get worse on narcotics. And after a month or so, it's tolerant. It doesn't do anything at all. So I try to avoid narcotics. It's not really helpful in the underlying causes of fibromyalgia, and you end up with an addicted patient. So fibromyalgia, as I started with, shares similar characteristics to encephalomyelitis, chronic fatigue syndrome, and long COVID. This has been studied quite seriously at Cleveland Clinic and Mayo Clinic for about the last 20 years. And this is where we first started to realize fibromyalgia has some encephalomyelitis changes on MRI and brain scan. There's fatigue, body pain, poor sleep, anxiety, and depression in all of these group of chronic fatigue. So in the last 20 years, looking at chronic fatigue, what they found is many patients trigger when they have a viral illness causing encephalomyelitis. So they've found chronic fatigue in this more than 3 months of pain and lousy sleep after Epstein-Barr, after Zika. Do you remember we had a big amount of Zika about 3-4 years ago? Coxsackie causes it. Lyme disease covers it. And we've known many Lyme patients who claim they are wiped out and sick from Lyme months and months after the Lyme has been treated. And now COVID. So it appears the virus causes an encephalomyelitis, changes the way the body perceives pain, and has interrupted sleep, and they just don't get over it. So if you think of it as a spectrum of disease, on one side, I put fibromyalgia because pain is a predominant complaint. Then they all have chronic fatigue. If you look at long COVID, there you have severe chronic fatigue, brain fog, anxiety, depression, not much pain. In a chronic fatigue long COVID case, if you do a trigger point exam, it's mild. They'll have some trigger points, but it's not 4+. So it's a less change. The way the virus affects the brain in that group of viruses seems to be mostly the brain fog and the absolute fatigue. But treatment's the same. So we want to see basically no lab work. And the patient wants lab work. They want someone to take them seriously. They want you to know that they feel horrible. So they keep saying, well, can't you test for it? Can't you do this? Can't you that? It really is not worthwhile. So labs and imaging studies are normal. Don't chase infectious possibilities since it does not impact treatment. So measuring for Coxsackie and RSV and flu and COVID and Epstein-Barr and everything you can think of on a panel. Okay, so one of them was positive. At some point in their life, they had Epstein-Barr. It's not treatable at this point. And when you're in the chronic fatigue syndrome, you're 3 months out, and it has never shown response to treatment of the virus at that stage. So looking for infectious possibilities is expensive and not worthwhile, and it causes the patient more anxiety. There are occasional patients with low thyroid, Hashimoto's, where they present with myalgias. They're painful all over, but they actually don't have trigger points. And so if you do a trigger point exam, you should be able to tell the difference. But a hypothyroid patient will present with fatigue and achiness in all their muscles because their thyroid's off. It is reasonable to check a TSH because that's fixable. So in our fibromyalgia treatment program, you want to focus on improvement in sleep and very gentle exercise. Symptoms improve with the serotonin, norepinephrine reuptake inhibitors. Cyclobenzaprine at bedtime sometimes helps relax their muscles and helps them feel sleepy. Avoid meds that disrupt the sleep cycle. Do not treat with steroids or narcotics. If they're on those things, try to get them off. Pace all of the exercises. Exercise actually improves mood, raises dopamine, and exercise improves sleep. But we have to be very careful the exercise is very slowly increased. Review sleep healthy habits. It's amazing how many people don't recognize that drinking Monster or something with a lot of caffeine at bedtime is not a good idea. So talk to them about their work. Do they work night shifts? And occasionally I've had a patient develop fibromyalgia because they are a paramedic or a fireman and they have to work at night. And they never worked night shifts before, or nurses who now have to work night shift. They don't deal well with night shifts because there's a diurnal variation of daytime and nighttime, and they need to stick to it. So I usually ask them to talk to their supervisor and see if we can switch to day shifts. Gabapentin, pregabalin, these drugs have shown mild improvement in clinical trials of FM, where half the patients got it, half the patients got placebo. There was improvement, but it's only about 10%. It's not much. I actually think the improvement is related to better sleep. Both of these drugs cause sedation. And if you take it at bedtime, it helps a little. My personal stepwise approach is I like to start with one thing, wait a month, and then do another thing. The one things we do want to do is the mindfulness, put them in control of their sleep habits and their exercise. So that's a base. And then on top of that, I usually like Elavil. Nowadays, they recommend the SSRIs. I do Elavil because that was the first one shown to treat fibromyalgia in a clinical trial. So it clearly has benefit. It makes them sleepy more than the SSRIs do. So I like Elavil. It's really small dose, 25 or maybe 50 milligrams at dinner. It will sedate them for 12 hours. So if they take it at bedtime, the problem is they can't get up in the morning and they're fatigued already. So you don't want to interrupt their ability to get up to work and do things. So it needs to be taken at dinner. And I usually write that right on the prescription, 6 p.m. And that way I have hope they can get up at 6 a.m. Cyclobenzaprine, you can add that on top of the Elavil as a time at bedtime. If they're going to bed at 11 o'clock at night, that's a good time to take the cyclobenzaprine. I consider Advil or some nonsteroidal to control OA if I found that a lot of their pain is related to their shoulder bursitis or their osteoarthritis of the spine. That I usually only give at bedtime with a little snack because I don't really want to keep them on nonsteroidals all the time, and I do want them to sleep. You can consider pregabalin or gabapentin at bedtime, but again, that would be in the 4th month of my trying to treat them. I don't do everything at once. What you do want, no matter what, from day one, get them to stretch a little bit, get them to walk 10 minutes every day, and make super simple adjustments to their sleep. So this is my little piece of paper I hand patients, and I have them write down on this calendar how much walking they did. So I want low impact exercise. Walking the dog is perfect. The dog needs to go out a couple times a day. If they do a 10-minute walk with the dog in the morning and in the late afternoon, that's ideal. Low impact, spaced over part. Other things can be worked very well with them. Anything that's low impact, swimming, dance. I have patients who do Zumba on their computer or something. Pilates, yoga, Tai Chi works very well, and that can be done online. Walking up to 30 minutes a day. So you start with 10 minutes a day, every single day for the week. So they fill out this form and they've done 10 minutes every day. The next week, I ask them to do 15-minute walk every day. If they don't do it every day that week, they did it twice. Then the following week, you stay at the same time. You stay at 15 minutes because you haven't done a full week of 15 minutes. We need to rebuild the core muscles and their muscle strength. So I need you to be aware there's also sometimes secondary gain going on. In fibromyalgia, there's often a family member who enables the FM patient. They just can't stand to see them in pain, and they hand them their narcotics, or they don't give them anything to do. They let them stay in bed all the time. They never fix dinner. They don't do chores, etc. That's not helpful. We actually want them to get up and down and to do light housework and light energy every day. Then they get better. So I like to assign the FM patient food marketing for the household. They should get food. So that gets them a cart they can lean on, and they can go for 10 minutes and go 10 minutes every day to the food store and pick up fresh vegetables. The FM patient is often attention seeking. They need to know you care. They want the family to recognize them. But that can be negative if the family starts doing things for them or making that out of balance with the household. If a family FM patient wants disability, I always deny it. If the patient's disabled, they're never going to do anything. And no exercise leads to a downward cycle and worse pain. You're not helping them by making them disabled. They should do what they can. Many of them now work at home from a computer, and they work for 10, 20 minutes, and then they do something else or lie down or relax or read a book, and then they come back and they work again a bit at the computer. Try to get the FM patient to invest in their own progress. Get them to accept that this is a long-term ongoing problem. Insist that the healthy sleep habits and exercise are a daily routine. I want to make a comment about ANA because as a rheumatologist, I get sent a lot of patients saying it's this lupus. Most ANA is benign. You expect a 1 to 40 in almost anyone. So seeing a 1 to 40 is perfectly benign. ANA also rises with age. ANA is the natural progression of ridding the cells that are old and getting new cells. Well, as you're older, your skin turnover and your gut turnover have more old cells. So the ANA by age 70 in almost everybody is 1 to 320. So the titer alone is not particularly helpful. It's the pattern that counts. So lupus is homogeneous. It should be a homogeneous pattern. Scleroderma is anticentromere. The benign ANA is speckled. So FM is usually going to be sent to you. It's a 1 to 40, it's 1 to 80, it's speckled. Let them know that's not lupus, that's a normal pattern ANA. It's fine. ANA does not give you the diagnosis of lupus. If you've looked at the long list of lupus symptoms, we give points for each of their symptoms. It has to be something we can see on physical or lab findings. Discoid changes in the skin, hypopigmentation, alopecia, big chunks of hair is missing. It looks like a quarter and there's no hair there. Synovitis, but no deformity. Pleurisy, pericarditis, a Coombs positive anemia, nephrotic syndrome, neutropenia, thrombocytopenia. These are things you can't miss. And the fibromyalgia patient doesn't have any of this. Don't go chasing lupus. That's not what they have. None of the lupus physical findings are seen in FM. Please don't order more and more and more serologies. It's not helpful and just raises the anxiety of the patient because they want to know, what does SM mean? For the future, there's a lot of research in the origins of the central pain signal. We now know that the pain signal is augmented. It's an aberrant dysregulation of interpreting pain. And there are little astrocyte packages that are sent from one astrocyte to the other as sphingosines. And these sphingolipids are what transfers the pain signal. So we're trying to block that. And fingolimod, which is a drug for MS, appears to decrease pain signals. And that may be borrowed from that research into FM research in the future. At the moment, it's not recommended. I just wanted you to know we are recognizing fibromyalgia as a real thing. They really do have pain they feel, and fatigue and anxiety and depression and insomnia. And we can fix some of it, but we can only improve 10% at most with any medication. What really changes it, it's their activities and their sleep. So the control is really in the patient's hands. And if they need a psychologist to help them with mindfulness programs so they recognize and appreciate what they do have and get them out of their own head a certain amount, those are positive steps, but they can be stuck in a fibromyalgia syndrome for years and years. It's long COVID. It looks similar, but we do now have enough years going by to see that most long COVID improves after 1 or 2 years. So be aware that the chronic fatigue syndromes are possibly post-viral as etiologies, but it's not at the stage that we can treat the virus. So I will take any questions now if that's useful. And thank you.
Dr. Greenwald, thank you so much for that great, very interesting, well-presented talk. So we do have some questions and just want to encourage people, if you have any questions, to put them in the Q&A icon that's on your Zoom toolbar. So Maria, here we go. Are there situations where there is low grade or other inflammation, but the ESR and CRP won't pick it up? Any use of doing high sensitivity CRP? And if so, when should we use it?
Short answer, no. If patients inflamed, the SED rate and CRP are elevated. They do measure different components of inflammation. They're both produced by the liver. Liver's what makes those proteins. And it's a filter. The liver filters all of the bloodstream and reacts as if there's inflammation present, either lymphocytes or neutrophils and so forth. And the SED rate will respond for a longer period of time. The CRP responds quicker. So when somebody has temporal arteritis, we will see the SED rate and the CRP both go up, but the SED rate stays up for about 14 days. So you have time to monitor a response. Fibromyalgia is not inflammatory. It should not have a CRP or a SED rate or a high sensitivity CRP. Those are not useful. The high sensitivity CRP is really used mostly in cardiac syndromes when patients are at high risk for another cardiac event. And the cardiologist may use that to help track if there's systemic inflammation going on. And a statin usually wipes that out. Statins are very good at anti-inflammatory. Statins do nothing for fibromyalgia. We don't have a drug for fibromyalgia, and fibromyalgia does not cause inflammation.
Great, thank you so much. Could mast cell activation syndrome masquerade as fibromyalgia? MCAS is when mast cells that release many inflammatory mediators are normal in amount, but dysfunctional in action and overaction.
I've never seen a case. I would assume those patients have very abnormal labs that you can track. So by definition, that's not fibromyalgia. Fibromyalgia does not have laboratory abnormalities. It's not something you're following because their mast cells are abnormal. I would not call that fibromyalgia. It certainly can give chronic fatigue or pain, but it's a different disease and the treatment should be different.
Thank you. What about brain retraining, like with DNRs, Gupta program, or primal trust to deal with changes seen in the brain? A lot of success has been seen to improve pain and quality of life with the use of these programs.
I think those programs are excellent choices. They are expensive. You may have trouble getting a pre-auth on it, but if their insurance covers it and the patient's willing to go through this, I think it's reasonable. The cell app things I was talking about is the same idea, getting people to accept their pain, deal with their pain, commit to doing some things in their lifestyle that will help them and try to put the retraining into their hands. But I do think retraining is useful. And years ago, I used to send patients who were bright. They had to be pretty smart. I would send with a psychologist and have them do brain retraining on computer programs where they would do matching and they would do all sorts of different computer games, thinking that we were retraining the brain.
Great, thank you so much. And Dr. Bautista writes that the Gupta program offers a free trial for 1 month and in different languages. Great. Chronic fibromyalgia can be induced due to a period of sleep deprivation due to underlying genetic predisposition, correct?
Yes, the genetic predisposition is only found in a small portion. So I wouldn't try tracking that. So if you think in terms of all breast cancers, some families have BRCA, but not all breast cancers are BRCA. So fibromyalgia does have a genetic component. I wouldn't test for it, but I wanted the clinicians to be aware of that because sometimes you'll see family clusters. You'll have a patient you're treating, and then you learn about the cousin or the aunt who has similar symptoms. I would encourage them to come see you, and start on treatment earlier is always better. The bulk of the fibromyalgia patients, we don't know why they have it. It's certainly not a genetic trait only, because we're seeing the same incidence in Bangladesh as we're seeing in South America, as we see in China, as we see in Canada. So it's not a genetic trait. Specifically, the bulk of fibromyalgia is probably related to a post-viral syndrome in many cases, or to sleep deprivation that kicked it off.
Thank you. And just to add to that previous question, so the time after childbirth is a high risk period for those with a genetic predisposition. Would we see a family history to help us know about this risk for the patient?
I have not seen any literature on postpartum fibromyalgia. You would think it would be happening because they're getting up so often with the babies. However, hormones are really different postpartum. It's certainly not low as it would be at perimenopause. So I'm not sure that the sleep deprivation by itself would be enough to cause it. On the other, because the patients have just had a baby, they're generally very happy. Their dopamine levels are really high. Yes, you get up every couple hours to feed the baby, but it's with a warm, happy ambiance. And I'm not sure that that's the setup where you see fibromyalgia. Also, in the studies where they caused fibromyalgia, they disrupted non-REM sleep, the deep sleep. And speaking for myself, I had 3 kids. I would breastfeed them and I fell asleep deep. And about 3 hours later, they woke me up and I'd feed them and then I'd fall asleep deep, but I would go under. So I'm not sure. And that was a personal anecdote that doesn't have any scientific value. But I have not come across any cases of FM after postpartum. There's certainly postpartum depression, but that's a different etiology.
Thank you. If a patient does not have the typical pain trigger point pattern and normal labs, would you still suspect fibromyalgia? What is the reason the test is no longer recommended for diagnosis?
I would say, given the current diagnosis definition,